your study has revealed about the effect it's having?
So this is a copy of the study, and there are copies in the back. I'm Lorin Ranbom. I'm Director of the Ohio Colleges of Medicine Government Resource Center. I'd like to thank Carolyn Knight and the DD Council for the opportunity to perform this evaluation of the buy-in program. We've developed a pretty strong relationship over a 2 or 3 year period with the DD Council and the Department of Developmental Disabilities and the disability community, and we're anxious to continue that. I understand how critically important the buy-in program is to the disability community. While I worked for the Ohio Medicaid program, I was privileged to estimate the budget for the Medicaid Buy-In Program in 2006 and 2007. I worked with the DD Council and the disability advocates to put a proposal together that was acceptable to the community and the legislature. Subsequently, I had a relative who became eligible for the buy-in program, not in Ohio, but in another state. And so I know just how meaningful it was to him to work and have the security of knowing that his health expenses were covered. So like Courtney, he is very emotional about those same kinds of things. So let me talk a little bit about the evaluation. This evaluation looked at 3 major issues. And starting with number 1, what is the likelihood that a disabled adult is working? And what does the Ohio Medicaid, and does the Ohio Medicaid program increase the chances that a disabled adult is working? Secondly, what are the characteristics of the buy-in population on Medicaid? How are they different from the non-buy-in disabled population? And as a result, are they better? Do they have better health outcomes? Are they healthier? And then third, this is an important time period in the evolution of Ohio's healthcare system, particularly because of the implementation of the Affordable Care Act, because the buy-in program's financial eligibility standards span the eligibility standard for Governor Kasich's Medicaid expansion proposal and the standards for the health insurance exchange. What are the likely impacts of the buy-in program beginning in 2014? So let me briefly outline some of these results. As of 2011, there were approximately 823,000 adults ages 19 to 64 who were disabled in Ohio. Of those who were disabled, 33% of them are on Medicaid. Of those on Medicaid and disabled, 15% of them are working. I think that's a pretty good number. We looked at other states in the Great Lakes region, and then there were some other states that had a better record and with respect to getting disabled workers, disabled people in working status, and some that didn't do as well as Ohio. We looked at the reasons why those were different. But we used predictive modeling, statistical techniques. Sorry, Barry. I said all that stuff. We found that disabled adults were 1.8 times more likely to be working if they were on Medicaid. This was true even after controlling for socio-demographic factors that influence employment participation. What this means is that the policies around Medicaid, particularly around the buy-in program, are actually working. They're getting more disabled people in employment status. So what about the question number 2, which was related to the health characteristics of the buy-in population compared to the other Medicaid-eligible disabled persons? Well, first of all, buy-in consumers have the same demographic characteristics as non-buy-in consumers that are disabled in the Medicaid program. If you look at things like percentage of the population that are married, African American, that are female, their income status, and their education. They look just like the rest of the Medicaid population. But they have very different clinical characteristics and much better outcomes. Other disabled Medicaid consumers were 2 times more likely to have multiple chronic physical and mental health conditions than buy-in consumers. But buy-in consumers were 7.9 times more likely to have a developmental disability than other Medicaid consumers. Other consumers had 2.8 times higher rate of inpatient hospitalization than the buy-in consumers, and 2 times higher rate of emergency department visits than buy-in participants. Even after controlling for clinical differences in the populations, the buy-in consumers still had a significantly lower rate of hospital admissions. So what does this all mean? Why are working disabled adults healthier? Are they healthier because they are working, or are they working because they're healthier? It's an argument that it's hard to establish causality, but we do know that the buy-in program for disabled consumers stops the ping-ponging between being healthy and non-healthy, and being working and non-working. And so, like Courtney, we have a constant a platform for her to survive and become successful as an adult. The last thing we talked about was, or we wrote about here, is the Affordable Care Act. The Affordable Care Act may have significant effects on the participation in buy-in beginning in 2014. I know all this stuff about the Affordable Care Act is very complicated, but what we've kind of boiled it down to is uninsured disabled workers facing the individual insurance mandate in 2014 and buy-in consumers not in long-term care settings below 138% of the poverty level could move over to the Medicaid expansion program if it gets enacted. Because there are no employment requirements and no requirements to certify that you're disabled in order to join that program. So the currently enrolled buy-in participants, about 37% of them, and when we did the study, there were, this was in, the data that we had was for the beginning of 2011, so we were working with about 6,000 enrollees in the program from that data. Now it's increased to over 8,500, but for the beginning of 2011, about 2,300 buy-in consumers were in that category. They were below 138% of the poverty level, but still above the Medicaid eligibility standard for disabled, which is 70% of the poverty level. Buy-in consumers above 138% of the poverty level could choose to stay in the buy-in program because, in fact, they probably would choose to stay in the buy-in program because the insurance premium requirements are much less and there are no cost-sharing requirements in buy-in compared to the health insurance exchange. When you heard Courtney talk that her premium was about $50, in the health insurance exchange it would probably be over $100. Those are the standards that they're using for the buy-in program, for the health insurance exchange. Of course, that's on a sliding fee scale as the buy-in program, but the buy-in program's premiums are significantly less than the health insurance exchange.